How's it going, guys? Past level question for renal. 68-year-old man, hypertension, type 2 diabetes mellitus. He undergoes coronary angiography for evaluation of unstable angina. 2 days later, he develops decreased urine output, swelling in his legs. He has a creatinine of 2.4. Should be 0.7 to 1.2. Once you've hit a creatinine of 2, you've lost 90% of your renal function. Prior to the procedure, he was upper and normal at 1.2. Urinalysis shows muddy brown granular cast. This is acute tubular necrosis, brown pigmented cast. He has mild proteinuria, and that could be from the ATN, but it's probably just from the background of diabetes mellitus, which causes nephrotic syndrome, but mild proteinuria, so he's not at overt nephrotic syndrome yet. No hematuria. The patient's medications include aspirin, metformin, lisinopril, atorvastatin. Which of the following preoperative interventions would most likely have prevented this complication? Choice A, administration 0.9% isotonic saline. Correct answer. Diagnosis is contrast nephropathy causing acute tubular necrosis. You need to know for USMLE that prior to giving IV contrast for anything, you need to copiously hydrate the patient with saline. Okay, and if you fail to hydrate a patient, the contrast can cause ATN. They really like that. All right. Now, when we talk about high yield etiologies for ATN on USMLE, acute ischemia, such as 30-second episode of ventricular fibrillation with decreased perfusion of the kidney, exsanguination, loss of blood during surgery, gunshot wound. So acute drop in perfusion of the kidney, that's ATN, not pre-renal. Pre-renal is more subacute to chronic, decreased perfusion of the kidney. NSAIDs, diuretic use, congestive heart failure, dehydration, vomiting over many days, okay? Diarrhea, vomiting over many days. That's all pre-renal. But if you have acute ischemia, that's ATN. Other causes, drugs like aminoglycosides, gentamicin, tobramycin, amikacin, cisplatin, chemotherapeutic agent, rhabdomyolysis, myoglobin is nephrotoxic, cause ATN, and IV contrast they really like, okay? So you have to give copious IV saline prior. So let's just hop through the others here. N-acetylcysteine is wrong. So N-acetylcysteine and bicarb have been floated as potential mitigators for contrast nephropathy in the literature, but the efficacy is debatable and they're wrong in USMLE. N-acetylcysteine, obviously, past level stuff is that it's the antidote for acetaminophen toxicity. So acetaminophen produces the toxic metabolite NAPQI. It's an oxidizing agent, converts reduced glutathione, which is an SH thiol group, into oxidized glutathione disulfide bond, SS. And so N-acetylcysteine will regenerate your reduced glutathione, your SH, your thiol groups. Wrong fucking answer. Choice C, discontinuation of metformin, wrong answer. Now, this could have been tricky. Now, this is about cause and effect. Okay, so this is what you gotta know. If a patient already has renal insufficiency, okay, so if you have a creatinine of 1.5 or greater, now we said 0.7, 1.2 is normal, yes. But for TCK step 3, you need to know that up to a creatinine of 1.4 is acceptable for metformin. But here's the deal. If you already have renal insufficiency, let's say a creatinine of 2, you would discontinue metformin in order to prevent lactic acidosis, okay? However, metformin in and of itself doesn't cause renal insufficiency. So that's where it can get a little bit confusing. The fact that the patient's on metformin prior to the procedure, that's not what caused the creatinine to go up. It would merely be that we look at a high creatinine now that it's already occurred and we say, well, it was the IV contrast that did that. But in general, we wouldn't want a patient who has high creatinine on metformin because now you could get lactic acidosis. A little bit tricky, but USMLE can throw this answer in alongside the hydration answer, okay? Finally, discontinuation of salicylates is wrong. So obviously salicylates can cause pre-renal effects, creatinine, BUN to creatinine ratio greater than 20, fractional excretion of sodium under 1%. Obviously, NSAIDs can do things like interstitial nephropathy. Obviously, your acid-base disturbances, so your mixed metabolic acidosis, respiratory alkalosis. But the NSAID in this case, we're not looking at a pre-renal cause. We're looking at the fact that we had a IV contrast administration followed by an acute rise in creatinine, so we know it's contrast nephropathy, not the NSAID here. Wrong fucking answer. Choice C, use lower dose of contrast. Wrong answer, even though some of you say, but wait, if we use lower dose, wouldn't we have a decreased chance of getting contrast nephropathy? Probably, but it's not like you're giving excessive dose of contrast to a patient when you do an intervention. You would use the minimum amount of contrast necessary to achieve the imaging you need. So yeah, in theory, you could give, let's say, 10% the dose, but then you also wouldn't get the imaging that you need. So it's a bit of an odd answer. Okay. So it's not a way that you'd prevent contrast nephropathy. You would give the minimum dose in order to achieve the imaging. Wrong fucking answer.